Thank you so much. So, starting from like 2 years ago, regarding like the LLM is like the gets a lot of eyeballs, even in the medical field, and we can see the AI doctors outside, just outside this outside this room. Our actually team focusing on the LLM, which is kind of like the after the deep learning is the AI, but that would be like a technical part. I will squeeze that. So we put different languages, like the images, like the medical records, like the EMR things, into this model, and that's the machine we are using. We have a contact with NVIDIA, and we have the contact with Peking University is the AI Academy. So we got our languages. So we are going to answer one question regarding the triage, even either in the emergency room or in the ambulance. So what we are looking for, like even the people in the emergency room. So whether or not you have the delay for the chest pain, not only depends on how quickly you go to the emergency room or how quickly you call the 911 or the 120 in China, but it depends on the person who answer your call, depends on the person who see you in the emergency room. So that's what we want to solve. Like we don't want to depend on the people. Probably one people today is better than the people the next day in the emergency room. So that's the question we are addressing. So before that, actually we compared our MediGuide. We call the MediGuide. Right now it's the 72B already. So compare the MediGuide with other LLM on the USMLE, on the CMC, another test in China, the European test or other test. That's kind of the medical knowledge. But not only the knowledge. So when we test the MediGuide, it's based on the 14B. But right now, when we go to the medical practice, it's like the 72B, which means like we think it's better than the 14B. So that's the hotline probably this year. And we have another RCT actually in North Europe. It's called the Mars ED study, but it's a kind of a little bit difference because they are using the machine learning and we are using the LLM. So, well, that I will squeeze that. And inclusion criteria will be like with the chest pain patients still in the emergency room. So actually we have the sister study want to go to the ambulance. And so it is on the study design already. And the purpose, we go a little bit like aggressive. Like, so on the first study design, we want to like the non-inferior, superior study design. But finally, we do the superior study design on the study, compare the emergency room triage with the people or the emergency room triage with the LLM. Well, it's still the RCT with the randomized. This the typo. It's not the observational. It's still the RCT, but we don't have the intervention. So the primary endpoint will be the accuracy, on the triage, and also we have the 30-day emergency readmission rate and the in-hospital mortality rate for the second endpoint. So that's our sample size calculation with a superiority margin at the 5%. So we estimate the sample size will be the 2,000 cases and 1,000 in each. That's the flow chart for the study. And based on that's the timeline, starting design, designing from last December, and we starting enrollment just 3 months ago, like the July this year. And based on last week data, we have enrolled 734 patients already, and we are looking for finishing the enrollment next year on March. And we have the 30 days follow-up. So basically, like in the middle of next year, we will got the result. So that's the potential limitation. We have the 4 centers already. It's not a single center in my hospital. That's the 4 centers elsewhere in Tianjin, Hebei, and Wuhan. Okay, that's it. That's the previous. We have the pilot study, and some papers on this field. So I will stop there. Thank you.